So what we'll do is today we do not have the liberty of revising again. Okay, since we have already revised it twice, the introduction to iceberg phenomenon, natural history of disease, why we do screening tests, and what is sensitivity, what is specificity, the basics. We do not have the opportunity to revise again because today is the last lecture of this particular sequence. Okay. So what we are going to do is today we'll just look at the slides that we have covered quickly. So we discussed iceberg phenomenon of disease, what are visible cases, what are hidden cases. We discussed what is screening, what are the key characteristics, the need for a detectable preclinical phase in screening tests, difference between screening test and diagnostic test, what is the purpose of screening, why we do screening, what are the different types of screening, a high risk approach, a population based approach, right? Evaluating the need, why we should do a screening test. There are some characteristics of the disease, some characteristics of the test, and some characteristics of the health system and treatment, isn't it? So we discussed that these characteristics are, it has to be an important public health problem, must have a recognizable preclinical phase, and an understood natural history of disease. Test characteristics, it must be valid, reliable, acceptable and safe. Treatment and health system characteristics, there must be available treatment, the health system must be able to scale the people it diagnoses, and the process must be cost effective. So if all of these parameters are met, then we say that okay, now we can do screening. Next we moved on to what are the harms of screening. We discussed that there can be some problems like overdiagnosis, false positive, false negatives and all of that. We discussed the epidemiological biases, length bias and lead time bias. And we discussed what are the common screening tests, what screening tests we employ for common cancers, what screening tests we employ for non-communicable diseases, what screening tests, and we looked at a review question. Once we have done this, today we will go into properly assessing a screening test, which is a proper screening test, which screening tests we can use, and based on what parameters we decide whether we can do screening or we should not do screening, right? So what are our objectives for today? We must be able to differentiate between reliability and validity of a screening test. We must be able to construct a 2x2 contingency table. As far as you are concerned, it is extremely important for your exams as well and for your postgraduate entrance exams as well, that you are able to understand how to construct a 2x2 table and what are the various parameters that we can gain out of that 2x2 table and what it essentially entails. Okay, it is very, very important. Next, from that 2x2 table, we will learn to calculate sensitivity, specificity, positive predictive value and negative predictive value. And we will realize when to prioritize which, when to prioritize sensitivity, when to prioritize specificity, when to prioritize positive predictive value and when to prioritize negative predictive value, right? So moving on, as we discussed already in the last class, that what are the characteristics of an ideal screening test. Now we know that an ideal screening test must be, test characteristics are that it must be acceptable. So what is acceptability? Acceptability means when I am giving it to the population, will the people agree to being subjected to that particular test, right? Next is safety, whether the test itself is causing some harm or not, right? Next is reliability, whether the test gives the same result on repeated administration, and whether the test is valid. Does it mean when the test measures something, does it actually give you what it is supposed to measure? Is it actually giving you the real parameter or not, or is it misguiding you? So that is validity. Now moving on, the difference between reliability and validity. We had already discussed this, that reliability is the ability of a test to give. What is reliability? It is the ability of a test to give repeated consistent results, isn't it? And what is validity? Validity is the ability of a test to give the correct or the accurate result. That is the ability of it to distinguish between people who have disease and people who do not have disease. So like we discussed in the case of Arjun, so this test, see the validity would be here, but this test has given the results, all of them clustered around one point, but away from the correct thing. So this test, the first one, it is reliable, but it is not valid. It is reliable, but it is not valid, the first one, giving the same accurate, same result on repeated thing, but deviation from the accuracy. So it is reliable, but not valid, first test. Look at the second test. See, the test has given different results. So it is not reliable, but if I take the average of all the results, then I will come to the midpoint only. So maybe it is somewhat valid on repeat measurements, but it is not reliable, because one time it is giving the result here, another time it is giving the result here, right? Next, if we look at this test, this one is neither reliable nor valid. It is giving widely dispersed results and they are away from the correct result. So neither reliable nor valid. And if you look at the last one, see, that is my ideal test, which is both valid and reliable. That is, it is hitting the bullseye as well as hitting the bullseye on repeat occasions. So that is a valid and reliable test. So a test can be highly reliable but invalid. At the same time, a test can be valid but unreliable. Okay. What we want is for the test to be both valid as well as reliable. Is this clear? So whenever we decide on a screening test, the screening test must be valid, the screening test must be reliable. Okay. Now comes to this, the epidemiologist's best friend, which is a 2x2 table. Now remember that why do we do screening? We do screening to identify underlying disease, isn't it? So whatever is the truth is thought to be is always presented in the top rows. Okay. Whatever is the truth, matlab over here I will always have disease present and disease absent. Realize that when we do screening, we do not know this. When we do screening, suppose we are doing on 1000 people, we do not know exactly who among them are disease positive and who among them are disease negative. But in order to estimate the validity or reliability of a screening test, we must be able to compare the screening test against the truth. So this kind of thing is only possible once we have done screening and then we have also done a test by a gold standard. For example, what can be a gold standard? For all kinds of disease that can be verified by pathology, like for example a biopsy. There the biopsy is definitely a gold standard. You have a tumor, you do a biopsy, you do the pathology staining and then you provide a diagnosis. That cannot be wrong, right? Because that is looking at the pathological characteristics of the cells, the tissue, the invasion, isn't it? So biopsy is considered as the gold standard. But then suppose I am also doing say again, if we take the example of breast cancer, if we are doing a USG, then the USG will be a screening test. The biopsy will be a gold standard. So when we construct a 2x2 table, we always keep disease present absent in the columns. And we keep the screening test we always keep it in the rows. Okay, the screening test we always keep it in the rows and the gold standard we always keep it in the columns. So then if I construct my 2x2 table, then understand the boxes now. Now look at this box. Who are there in this box? The people who are there in this box are being called true positive. Why true positive? Because in reality they have the disease. and the screening test, in reality they have the disease, and the screening test has also found the disease in them. So the screening test has labeled them as positive when they are really positive. So these people are the true positives, right? Then we have another group of people who really do not have the disease, and the screening test has also been able to find out that they do not have the disease. And these people we call as true negatives. Always remember that when we employ a screening test, our objective is to maximize these two squares. Our objective will be to maximize these two squares, so that all people who have the disease are labeled as diseased, and all people who do not have the disease are labeled as not diseased. That is my objective. But when I try to do that, something else will also happen. What will happen? The screening test, in its attempt to detect disease among those who have disease, will end up detecting disease in some people who do not have the disease. So what is the screening test telling me? That these people have the disease. That is, the screening test is telling that these people are also positive. But is that positive true? No, because in reality they do not have the disease. So this square we call as false positive. The square B, disease is really absent, but the screening test by mistake, it labels them as positive. So this is a problem, false positive. Again, we have some people who really have the disease, but the screening test labels them as negative. That means the screening test is labeling them as negative, but the reality is that they have positive. So again, this negative is false. So in this box we call them false negative. So remember that the naming is always with respect to whether we name it positive or negative, is always with respect to what the screening test is finding. And the judgment of true or false is always with respect to the gold standard or the diagnostic test. If the gold standard is agreeing with the screening test, then it is true. If the gold standard is not agreeing with the screening test, then it is false. But whether it is positive or negative depends on the screening test. So all people who the screening test labels as positive are positive. If the gold standard agrees, they are true positive. If the gold standard does not agree, they are false positive. All people whom the screening test labels as negative, they are negatives. If the gold standard agrees that they are negative, then it is true negative. If the gold standard does not agree that they are negative, then it is false negative. So what will be our objective in selecting a test? Our objective will be to maximize which two and to minimize which two? Our objective will be to maximize which two squares and minimize which two squares? True positive and true negative we will want to maximize, and false positive and false negative we will want to minimize. So if we are having, when we discuss the biases or the harms of screening, see, we discussed that the harms of screening include false positives and false negatives. So we must reduce those two squares when we are employing a screening test, isn't it? So always remember how to construct this table. Though we call this a 2 cross 2 table, it is essentially, when you draw it, it has to be drawn like a 4 cross 4 table. Where in the 2 cross 2 section, you will have your main table. But in the 4 cross 4 section, 1 column and 1 row will be used for the headings, and 1 row and 1 column will be used as the totals, isn't it? So always construct the 2 cross 2 table as a 4 cross 4 table. So this is the total number of test positives. This is the total number of test negatives. This is the total number of disease positive. Total disease positive. This is total disease negative. This is the table total. This is total test positive and this is total test negative. When you are given a problem sum, you will not be given all of the inside squares. These will all not be given. You will be given these things and either of these. You have to find out the others and complete the table first. Okay, so whenever you get a problem for sensitivity, specificity, always remember that what you have to do is you have to first construct a 2 cross 2 table, and a 2 cross 2 table is properly drawn as a 4 cross 4 table where we use 1 row and 1 column for headings and 1 row and 1 column for totals, and the middle 4 squares are used as the 2 cross 2 table proper. Is that clear with everyone? Is this table clear to everyone? This is the basis of today's discussion. If this is not clear, anything after this will not be understandable. Any confusion in this table? So suppose we are doing USG and biopsy. Then USG will stay here, USG positive, USG negative, and biopsy positive, biopsy negative, right? So there will be some people whom the USG labels as breast cancer, but on biopsy you find that they have breast cancer. They will be true positives. USG labels as breast cancer, biopsy finds that they do not have breast cancer. They are false positive. USG rules out that these people do not have breast cancer, but on biopsy you find that there is some cancerous cells that are there. That is false negative. USG says no disease, biopsy also does and finds no disease, that is true negative, right? So this is how we classify our entire population based on the screening test and the confirmatory test. So moving on, the first parameter that we need to study, which is known as sensitivity. So what is sensitivity? Sensitivity is the ability of a test to detect those who have the disease. It is the ability of the test to those who have the disease. Now tell me, what will be the numerator then? If I want to establish ability of a test to detect those who have the disease. So when is this test detecting those who have the disease? In which of these squares? In which of these 4 squares is the screening test detecting those who have the disease? True positives, isn't it? So the true positives will be the numerator of sensitivity. Ability of the test to those who have the disease, then definitely true positive will be the numerator. What will be the denominator? All of those people who have the disease. I want to find out among all of those people who have the disease, how many is the screening test able to decide, isn't it? So all of those who have the disease are where? Look at this. All of those who have the disease are where? Total of people who have the disease. All of those who have the disease are here, total of people who have the disease, and the screening test is correctly able to identify the true positives, isn't it? So the numerator for sensitivity will be true positive, the denominator for sensitivity will be of those who have the disease. So basically it is all of those who have the disease includes true positives and false negatives. That is, people who have the disease and screening test has found out the disease in them, true positives, and people who have the disease but screening test has labeled them as negative. They are false negatives. So sensitivity is defined as A by A plus C into 100 as a percentage. So we give the names, we name them like this, the boxes we name them like this, A, B, C, D. So definitely this will be A plus C, this will be B plus D, this will be A plus B, this will be C plus D. Always remember this you cannot do according to your whims and choices. You cannot write that this is A, this is B, this is C, this is D. No. This is the convention, you have to do this. A, B, C, D. Okay. So true positives is represented by the box A and false negatives are represented by the box C. So sensitivity is given by A plus C into 100. Right? A plus C represents what? A plus C represents all of those who have the disease. And among that, A is representing sensitivity. That is, how many the test is able to find that these people have the disease. Is that clear? Any confusion? So sensitivity is ability of a test to correctly identify the disease among those who have the disease, right? So basically think we are trying to do sensitivity from a population perspective. In the population, how many people who are really diseased can I detect by the screening test? That is what sensitivity is telling me, isn't it? So if you want to remember it by a mnemonic, remember it by SNOUT. That is, sensitive test when negative rules out the disease. Isn't it? A sensitive test, because sensitivity will be maximum when? When will sensitivity be close to 100? Sensitivity will be close to 100 when? If sensitivity is equal to A by A plus C into 100%, then when will sensitivity be close to 100? If C equals to 0, if C tends to 0, that means not a single person who has the disease is given a negative result by the test, isn't it? So a sensitive test is able to rule out the disease when it is negative. A sensitive test is able to rule out the disease when it is negative. Clear? Next we move on to the next parameter, which is known as specificity. So what is sensitivity then? Sensitivity is the ability to detect disease among those who are diseased. What is specificity? Specificity is the ability of a test to correctly find out those who do not have the disease. Means, among those who really do not have the disease, how many is the test able to label that these people do not have the disease? It is just the opposite of sensitivity. Sensitivity was among all the people who have the disease, how many is the test able to label as diseased? Specificity is among the people who do not have the disease, how many is the test able to label as not diseased? So what will be the numerator here again? The numerator will be D, true negatives, and the denominator will be B plus D. The numerator will be B plus D. So specificity is given by B plus D into 100%. B by B plus D into 100%, because B plus D is representing all of those who do not have the disease, and B is among them how many is the test able to label as not diseased, isn't it? So our objective here is to minimize this. Our objective is to minimize this, that those who do not have the disease should not by any chance be labeled as having the disease by the test. So when the test says that you do not have the disease, that means you do not have the disease. You cannot have the ability of having the disease if the test says that you do not have the disease, isn't it? So as we have already discussed, it represents that B by B plus D into 100, isn't it? So a highly specific disease is very effectively able to rule out disease. That means if it is positive, that means you definitely have the disease. If the test is very good in ruling out the disease, that means if it gives a negative result, if it is very accurate, that means if the specific test is giving a positive result, that means there is a high likelihood that the disease is present, So sensitivity helps us to rule out disease. Specificity helps us to detect disease. The term is also like that. Sensitive means I do not want to miss anything. So a sensitive test helps us to rule out disease. A specific test, once I have found out them, now I want to see how many really have the disease. So that is when we employ a specific test. A specific test helps us to rule in the disease. The test is specific for that disease. It finds that disease with a lot of accuracy. A sensitive test rules out a disease with lot of accuracy. So one summary thing to remember is that sensitivity and specificity are both column parameters of the 2x2 table. Sensitivity and specificity are both column parameters of the 2x2 table, isn't it? When we are doing it on the first column, we are getting sensitivity. When we are doing it on the second column, we are getting specificity. Are we clear so far? Is it okay, or everything is going above head? So a new rapid test for tuberculosis is examined against sputum culture, which is the gold standard in 1000 individuals, right? True TB cases is 200. True TB cases is 200. Healthy individuals is 800. Test positive in true TB is 160. Test positive in healthy is 80. Right. So can you formulate the 2x2 table first? Can you formulate the 2x2 table quickly? Or just tell me true TB cases. This is showing which box? No, this is true TB cases. That means A plus C. It has given you the disease total. How many people really have the disease? True TB cases. So 200 is the disease total. It is A plus C. Healthy individuals 800. That means which box? Which box? B plus D. B plus D. Disease negative. So these are the healthy individuals. So total were 1000. So if disease positive is 200, disease negative has to be 800. Total has to be 1000. Isn't it? If 200 have TB, then 800 automatically don't have TB. So that is what the first two statements have given you. Next two statement, test positive in true TB. That means which box? Yes, test positive in true TB is true positive. They have TB and the test has also found out that they have TB. So that's true positive. And test positive in healthy, that means false positive. So it has given you these two totals and it has given you these two boxes. So effectively you can find the all other boxes, isn't it? By simple subtraction addition, you can find out all the other boxes. This is how you will be given problems. Okay. So it will be like this. Is this all right? So they gave 160, they gave 80, they gave 200, they gave 800. By subtracting we can find 720 and 40, and by adding we'll get 240, 760. Is it clear? Is this 2 cross 2 table clear to everyone? Has anyone got different results? Do you have any questions? Please ask. Is it okay? All right. So then automatically sensitivity is true positive by disease positive. A by A plus C, true positive by disease positive, coming as 80%. And specificity is true negative by disease negative. So that is again coming as 90%. So how good is this test as a screening test? It is okay. It is okay. It is not very good. Why? Because 40 people who have tuberculosis are being assured that they do not have tuberculosis. Because in reality, I am not doing both. I will do only one. I will do only the screening test. So the screening test is labeling 40 people out of 200. It is giving them a false assurance that they do not have the disease when they actually have the disease. Those 40 people are going to die. Those 40 people are going to develop severe forms of tuberculosis. Those 40 people are going to go back into the community and infect 10 new people with tuberculosis. So a screening test must be sensitive. A screening test must be very sensitive. Sensitivity is very, very important for screening tests. 80% sensitivity is not good for a single screening test. Okay. Even though this is specific, what it does well is it does not give the burden of giving a diagnosis in those who don't have the disease. But still 80 people who do not have the disease are labeled. But still it's okay. But 40 people who have tuberculosis are labeled as not having tuberculosis. That is a big problem. That is a big problem. Okay. So is this clear? This sum was given. This is the 2 cross 2 table that you must find out. When you are given this problem in the exam, you must first formulate the 2 cross 2 table. Then you have to define sensitivity, write its formula, do the calculation and give a comment. Then again define specificity, write its formula, do the calculation and give a comment. Then only you will get full marks. Okay, don't just do it like this. Sensitivity ato by ato percent. No. First do the 2 cross 2 table, define sensitivity, write the formula, do the sum, give the comment, define specificity, write the formula, do the sum, give a comment. Okay? Is that clear to everyone? This will be mandatory in all of your practical exams. Right? One sum from sensitivity, specificity, positive predictive value, negative predictive value will be there for everyone. Now is what to prioritize. See, it so happens that if you increase the sensitivity of a test, the specificity automatically goes down. And if you increase the specificity of a test, the sensitivity goes down. the more you make the test ability to detect the disease, it will end up detecting disease in some people who do not have that disease. The more you make the table able to rule out disease, it will rule out disease in some people who have the disease. So we always have to go for a balance between sensitivity and specificity. If we maximize sensitivity, specificity goes down. And if we maximize specificity, then sensitivity goes down. Okay. So that is what I want to show you here. That is the trade-off between sensitivity and specificity. Okay. Imagine you think of people having diabetes. Okay. Now imagine that this right one, this represents the diabetic people. This represents the diabetic people, this one. And imagine this one represents the healthy people. This one represents the healthy people. This is the fasting blood sugar. Okay, x-axis is the fasting blood sugar, y-axis is the number of people. Right? The first hump represents the healthy people. The second hump represents the diabetic people. Now imagine we have what is the current cutoff of diagnosing people with diabetes with fasting blood sugar? 126, isn't it? Let y be 126. Let y be 126. Okay. Now if y is 126, look at what we do if y is 126. If y is 126, then who will be true positives? If y is 126, who will be true positives? This part. People who have diabetes, and by y you are also labeling that they have diabetes. So this part is being labeled as true positive. Who are true negative? People in this hump. Before y, people in the first hump who are falling before y. These are true negative. They do not have diabetes and you are labeling that they do not have diabetes. Who are false positive? If I am using y as cutoff, who are false positive? Can you try and think who are false positive? What is false positive? What is false positive? People who do not have the disease but are being labeled as diseased. So who are false positive if I am using y as the cutoff? See these people. Isn't it? People falling between y and z here are the false positives. Isn't it? Who are the false negatives? X, Y triangle, this one. This one. This one are the false negatives. They are part of this hump, but they are staying undetected. Isn't it? So by staying the cutoff at y, we are having a balance between false negatives and false positives. Now suppose I move the cutoff from y to z. I say that fasting blood sugar cutoff to diagnose diabetics will be z, that is 150. What will happen? If I make the cutoff at z, what will happen? Now, who are true positives? This part. Who are true negatives? Everyone who does not have the disease is labeled negative. So everyone in that first hump is true negative. So how many false positives? If I move the cutoff to z, how many false positives? 0, 0, no false positive. Everyone is a true negative. If everyone is a true negative, that means there are no false positives. How many false negatives? Huge. Huge. People who have the disease but have been not diagnosed by the test. Huge number of people who are false negatives. So see, if I move the cutoff to Z, what has happened? False positives has gone to 0. That means specificity has become maximum. But false negatives has increased by a lot. That means sensitivity has gone to the drain. Sensitivity is now lying in the drain. So if we increase the cutoff, we compromise on sensitivity while increasing the specificity. Now imagine we do the opposite. Instead of increasing from 126 to 150, we decrease it from 126 to 100. The pharma industry gives us a lot of pressure. Metformin is not selling enough. I want more metformin to be sold. So you reduce the cutoff. And say we reduce the cutoff from 126 to 100. So if the cutoff is reduced from 126 to 100, then what is happening to true positives? Everyone is a true positive. Everyone who is diabetic gets labeled as a diabetic if my cutoff is at X. So false negative is 0. That means sensitivity is maximum. But what is happening? I am diagnosing a lot of healthy people as diabetic. A lot of people who do not have diabetes, maybe just had one extra rasgulla yesterday night, they are coming as diabetics. So I am having a lot of false positive. So when I am prioritizing sensitivity, my specificity is going to the drain. So eventually what we have to do is we have to arrive at a balance between sensitivity and specificity. Okay. So depending on the disease characteristics, depending on the healthcare system's ability, we go for a middle ground. So as you can see, lowering the cutoff point, it increases the sensitivity, reduces the specificity. Raising the cutoff point reduces the sensitivity, increases the specificity. So always what we have to do, we have to arrive at a balance. So when to prioritize sensitivity? That is, I do not want to miss any case. If the disease is highly lethal, if the disease is very easily treatable, and if false positives do not cause serious trauma. If false positives do not cause serious trauma. Many a times a false positive test can change a person's life. For example, a HIV diagnosis. We cannot afford to give anyone a false positive HIV diagnosis. Then we will not prioritize sensitivity. Okay. But for example, it's COVID. Then false positives are still fine as long as I do not have false negatives. Because false negatives will go into the community and spread it into 100 more people. Okay. So we prioritize sensitivity when the disease is very lethal or severe, and early detection helps. If the disease is easily treatable and the treatment is relatively harmless, and if we have false positives which do not cause a lot of emotional trauma. Next, when to prioritize specificity? When to prioritize specificity? When to prioritize specificity? In the opposite case, when a false positive result can lead to severe trauma, then we will prioritize specificity, isn't it? If the treatment is highly dangerous or mutilating, for example, cancer, I will avoid false positives, isn't it? Chemotherapy will cause someone to become bald. Very problematic. Radical mastectomy, very problematic. Limb amputation, very problematic. We cannot afford to have false positives, right? So their specificity is of utmost importance. So always remember that when we are thinking of diagnosis, when we are thinking of giving people a diagnosis, our priority is specificity. When we are thinking of screening, our priority is sensitivity. So for screening, we will always and always prioritize sensitivity. For diagnosis, we will always and always prioritize specificity. Is this clear? So far, are we good? Are we good to go so far? Okay. So I thought I would go into positive predictive value and negative predictive value also today, but I'll keep another session for that. And we'll take another session to finish that part, positive predictive value, negative predictive value, and doing tests in parallel and sequence. Okay. So I'll just go to one more slide that look at a clinician's dilemma. When we are doing a screening test, we are employing sensitivity or specificity. But is that what you are concerned with when you are a clinician? What is sensitivity or specificity telling you? It is how many people among the population the test will be able to detect, how many people among the population the test will be able to eliminate. That is what they are telling you. But what does a clinician want to know? Suppose you are there in the emergency, a person comes with chest pain, you do a TROP-T. What do you want to know? Do you want to know that how many people having chest pain, of them how many the TROP-T will be able to detect? Do you want to know how many people not having chest pain, how many the TROP-T will be able to exclude? Do you want to know these things? No. You want to know one simple thing. This person has come with a chest pain. I have got a TROP-T positive result. What is the probability that this TROP-T positive means they actually have a acute myocardial infarction? Isn't it? What is the probability that giving a positive result with TROP-T actually means that they have the myocardial infarction? Because once I get a TROP-T positive, I'll make them go and do a angio and stenting. That's expensive, isn't it? So far what we have discussed has answered the epidemiologist's problem, the public health problem, but it has not yet answered the clinician's problem. That is, suppose, okay, someone has come with a chest pain and TROP-T has come negative. Can I send this patient away? Can I say that, okay, TROP-T negative means that you do not have disease? Can I do that? So what is the probability that a negative test means absence of disease? Isn't it? That is what a clinician wants to know, and that is what we will discuss in the next class, which is what is a clinician's dilemma when employing a screening test and a diagnostic test, and how to answer that dilemma, right? So next time when you look at a lipid profile and you find a perfectly healthy individual having a good BMI, athlete's body, regularly exercises, has a very good diet, sleeps well, and only the total cholesterol is maybe 5 points higher than the guidelines. Always remember this curve. Remember that our curves are based on a balance between sensitivity and specificity. So with every cutoff that is there on a lab parameter guideline, we might be diagnosing some healthy people as diseased. So do not treat reports, treat individuals. Look at the patient. If they are healthy, not having any signs of insulin resistance, have a good diet, sleep well, exercise regularly, do not show the risk factors of cardiovascular disease, do not label someone as diabetic, just because the fasting blood sugar is little bit elevated. Always do the battery of investigations, take proper history, ask for follow-up tests, wait and watch. Do not jump into treat reports, treat the patient. Okay, so with that note, we will conclude today's discussion and we'll begin with positive predictive value and negative predictive value in the next session.